Thank you for the introduction. Dear colleagues, firstly, I would like to thank the company Merck for the organization of this very important conference. Dr. Agarwal, thank you for this extensive presentation of diagnostic tools in male infertility. So I will have it probably easier in my talk. Thank you for the invitation. It's my pleasure to have the opportunity to talk about treatment options in male infertility. These are my disclosures. The lifetime prevalence of infertility of couples of reproductive age is about 15%. In 50% of involuntarily childless couples, the male factor is present. There is a variety of causes of male infertility. Some of them can and some of them cannot be treated. The different treatment options range from lifestyle changes to medical and/or surgical treatment. Lifestyle factors may contribute to the male infertility. Obesity is associated with impaired sperm parameters. Weight loss after 8 weeks of low-calorie diet improved sperm concentration and sperm count. The maintenance of the weight loss by physical activity and/or administration of GLP-1 agonists maintained the positive effect of weight loss on sperm concentration, but did not improve sperm motility. A meta-analysis of 28 studies with more than 1,000 patients enrolled showed that bariatric surgery does not improve semen parameters in morbidly obese men. In 37% of all men of reproductive age smoke cigarettes. Exposure to cigarette smoking reduces sperm count, sperm morphology, and sperm motility. The deterioration is more pronounced in heavy smokers. Experimental studies on rats showed that semen parameters may improve after nicotine cessation. A moderate alcohol consumption does not adversely affect semen parameters, whereas a high dose intake may have a detrimental effect. According to the European EU guideline, lifestyle changes may improve male fertility. The therapy with gonadotropins is well established in hypogonadotropic hypogonadism. Usually, ACG and FSH are used to stimulate spermatogenesis. One positive parameter, predictive parameter of the therapy is a history of a normal puberty. That is the case if the hypogonadotropic hypogonadism occurred after the puberty or the puberty was induced medically. Another positive predictive factor are the absence of the history of cryptorchism, a higher testicular volume, and inhibin B level before the start of the treatment. The therapy is monitored by the measurement of the testicular volume, FSH, and testosterone levels, and mostly important, semen assessment. The duration of the therapy may be 2 years and longer before sperm occurs in the ejaculate. With the therapy, 40 to 55% of couples will achieve a spontaneous pregnancy. In 15 to 25%, couples will need assisted reproductive treatment. If no sperm occurs in the ejaculate, the patient should be transferred to the testicular sperm extraction. There is evidence of 5 randomized controlled trials with more than 650 patients enrolled that FSH treatment may improve semen parameters in idiopathic male oligozoospermia with FSH levels within the normal range. A high-dose FSH therapy is more effective than low dose. And another meta-analysis with different treatment protocols and different duration of follow-up concluded that FSH treatment improves pregnancy rates, both spontaneous and after assisted reproductive treatment in idiopathic male infertility. FSH may also improve DNA integrity. This effect depended on the FSH receptor polymorphism. Recently published real-world data showed an increase of sperm count, an increased proportion of normozoospermia, a decreased proportion of azoospermia, and a pregnancy rate of 27.6%, half of the pregnancies occurring spontaneously after the administration of FSH to idiopathic male patients. According to the EAU guideline, the level of evidence is high supporting the therapy with gonadotropins in hypogonadotropic hypogonadism. Even though the level of evidence is lower, the guideline recommends FSH treatment in idiopathic male infertility with FSH levels within the normal range. The guideline is restraining in advocating FSH treatment in patients with non-obstructive azoospermia prior testicular sperm retrieval. Antioxidative stress, we already heard about it, has been considered as an important contributing factor in the pathogenesis of male infertility. Reactive oxygen species may adversely affect spermatogenesis and sperm function. Semen levels of ROS have been negatively correlated with the outcome of assisted reproductive treatments. However, the role for the antioxidant therapy in infertile patients is more conflicting. A meta-analysis of 61 studies with more than 6,200 patients enrolled using different antioxidant compounds showed a positive impact on live birth rates of antioxidant treatment. More recently published MOXIE trial failed to show an increase in sperm concentration, DNA integrity, and live birth rates after the administration of antioxidants if compared to placebo among infertile men. Selective estrogen receptor modulators have been advocated as an empirical treatment of idiopathic male infertility. The proposed mechanism of action is a blockage of FSH receptors at the level of the hypothalamus, resulting in an increase of the gonadotropin release. Meta-analyzed data from 16 studies showed an increase in pregnancy rates, sperm count, and associated hormones after the administration of selective estrogen receptor modulators. Aromatase inhibitors may downregulate the negative feedback of estrogens on hypothalamus, again resulting in an increased gonadotropin release. Aromatase inhibitors do not improve pregnancy rates. Even though there are some promising data, the level of evidence is low and does not support, at least in general, medical treatment in idiopathic male infertility except of FSH. In some special cases, the medical treatment may be helpful. The varicocele has been the subject of debate for decades. The varicocele is present in 15% of all men, in 25% of men with abnormal semen parameters, and in 35 to 40% of patients with infertility. So the vast majority of men with the varicocele has a normal fertility. These data are almost 30 years old, but however, they show that in the infertility treatment, the varicocele repair may be as effective as counseling. Recently, Professor Agarwal and his working group published data from 16 controlled studies with more than 2,400 patients enrolled. Patients in the treatment group and in the control group had semen assessment over the same period of time. Patients in the treatment group had a significant increase of sperm parameters after the treatment of the varicocele if compared to the controls. The varicocele repair may also improve DNA integrity in sperm, especially in patients with elevated DNA fragmentation. Further, the varicocele repair may increase the sperm retrieval rate in patients with non-obstructive azoospermia. In 44% of patients, sperm occurred in the ejaculate after the varicocele repair with good pregnancy results. The therapy options are either surgical or interventional. With the data we have today, the microscopic varicocele repair has the lowest complications and the fewest recurrence and hydrocele formation rates. With the laparoscopic approach, very good results can be achieved too. Radiological interventions are at least invasive. The European EAU and EAA, as well as the ISRM guideline, the North American guideline, recommend the treatment of the clinical varicocele in infertile patients with impaired semen parameters. The EAU guideline also regards and takes the ovarian function of the female partner into consideration, just because it usually takes at least several months before the treatment success of the varicocele repair can be observed. The EAU guideline also respects the indication of the varicocele repair in patients with elevated DNA fragmentation. In the North American ISRM guideline, the varicocele repair in patients with non-obstructive azoospermia is discussed but not fully supported. The EAA guideline does not define subgroups in patients with clinical varicocele. We are now approaching to azoospermia. There are two major groups of azoospermia, obstructive and non-obstructive. The obstructive azoospermia is less common and appears in 20 to 40% of all patients with azoospermia. The obstruction may be at any level of the genital tract, but the level of the obstruction cannot always be defined. Patients with obstructive azoospermia usually have normal FSH, testosterone, and testicular volume. The epididymis might be enlarged. However, patients with non-obstructive azoospermia and late maturation arrest may also have normal FSH, testosterone, and testicular volume, so these two groups of patients may not always be easily distinguished. In the obstructive azoospermia, the reconstruction is the preferred strategy. The aim is the occurrence of sperm in the ejaculate, and spontaneous pregnancy as an optimal result. If the reconstruction is not possible, an epididymal and/or testicular sperm retrieval should be performed. In the non-obstructive azoospermia, the aim is to find sperm in the testicular tissue and to use it for ICSI. And it's challenging. The conventional teaser requires an scrotal incision and an open biopsy of the testicular tissue. The probability to find sperm is about 50%. FSH, LH, testosterone, and testicular volume have been correlated with the outcome of the testicular sperm retrieval with conflicting results. No clinical variable can be currently considered as a reliable predictive parameter of the positive sperm retrieval. Observational studies showed that with multiple and multifocal biopsies, a higher sperm retrieval rate can be achieved. A microscopic surgical technique requires a surgical microscope. The tubules seminiferæ are examined at a magnification of 20 to 25-fold, and those that are enlarged are extracted as they are more likely to harbor sperm. With microteaser, a higher sperm retrieval rate could be achieved. With less tissue extracted, much more sperm could be found. A meta-analysis that pulled data from case-controlled studies confirmed a higher sperm retrieval rate for microteaser. With salvage microteaser, the probability to find sperm was acceptably high even in cases when no sperm was found with a conventional teaser previously. A more recently published meta-analysis showed no difference in sperm retrieval rate between microteaser and conventional teaser. These results caused a lot of debate and issues could be found. Not only studies that compared both surgical techniques, case series for microteaser and conventional teaser alone were included. The rate of patients with a poor prognosis was significantly higher in the microteaser group. If the data analysis was limited to the comparative studies, the sperm retrieval rate was significantly higher in the microteaser group. The results also favored microteaser if only studies were included that provided information on histological findings. There are some open questions. Does it make sense to differentiate the teaser material in sperm found or sperm not found? Or should additional parameters be included? And how many visual fields should be examined by the embryologist before the diagnosis may be set? So consequently, what are the requirements of the teaser material to further proceed with ICSI, and when maybe the couple should be advised for alternatives? Do certain groups of patients benefit from medical pretreatment and/or fresh teaser ICSI? The EU guideline evaluates the microteaser as a favorable surgical technique in patients with non-obstructive azoospermia. The North American ISRM guidelines regards the microteaser only. There are some data supporting the use of testicular sperm in patients with elevated DNA fragmentation in ejaculated sperm. A higher pregnancy and live birth rates have already been reported. However, the level of evidence is low to moderate, as prospective randomized trials are missing. The use of testicular sperm in cryptotzoospermia does not improve the outcome of the ICSI treatment. However, additional data are needed to support the evidence also for this group of patients. According to the EAA guideline, the use of testicular sperm may be discussed with patients with elevated DNA fragmentation after the failure of the assisted reproductive treatment with ejaculated sperm. These are my take-home messages. Lifestyle changes may improve male fertility. There is a strong evidence supporting the treatment with gonadotropins in hypogonadotropic hypogonadism. There is a rising evidence for the FSH treatment in patients with idiopathic infertility. Patients undergoing the varicocele repair should be properly selected, and with the micro-T, a higher sperm retrieval rate may probably be achieved than with the conventional T. Thank you.